Hi, so welcome. And today I'm joined by Sarah Norris. And Sarah is a musculoskeletal and pelvic health physio. And she's also a clinic director of a wonderful practice in Liverpool, both in North and South Liverpool. And we're going to talk to you today about the pelvic floor. And as you know, one of my passions, some of you know, is really raising awareness about the importance of our pelvic floor health. So Sarah, first I'd love to hear, thank you for joining us first of all, and I'd love to hear a little bit about you and your practice, and tell me a bit about what you do. What is a pelvic health physio?
So my background is I qualified as a physio in 2001 and I became a musculoskeletal physiotherapist quite early on, Pilates instructor. And if truth be told, I just organically fell into the world of pelvic health. Honestly, hand on heart, if you would have said to me 15 years ago, Sarah, you'll be a pelvic health physio, I would have laughed at you.
Okay.
I was presented, though, throughout my career with so many women who had lots of secrets to share. They thought they were secrets. They didn't want to disclose them to anybody else. And I was often the one that, was the first to hear about their problems. And to be honest, I tried referring and working with different practitioners, but lots of these ladies had issues that I could actually treat as well as a musculoskeletal physiotherapist. So my skills just developed and evolved. And I do like to recognise myself as an MSK and a pelvic health physio. So literally now we've built in the clinics a women's health and men's health service from scratch. And it's still our fastest growing service. So it's amazing. Literally I feel, to be honest, like we're still just scratching the surface with it.
Well, that's it, because I find so many people have never even heard of a pelvic health physio or a pelvic floor physio at all, have they?
No. I mean, I think we used to, traditionally in the hospitals, the NHS, where I used to work for a few years at the start of my career, it was always the women's health physiotherapy department.
Yep.
Now the hospitals have obviously tapped into the male pelvic health as well, and, we sort of call them pelvic health departments.
Yep.
You're right. Not many people really understand the role of a physio. I mean, most people think that a physio is there just for tissue treatment anyway.
Yep.
So when you sort of tell them that you do lots of pelvic health things, I think that many people don't really understand what we actually do.
Yeah. So tell me what you do. What sort of issues do people come with, the secrets that they share, just to give us a flavour of the range of the sort of people and the conditions?
Because I was an MSK physio and taught Pilates, lots of women would come to me post-gynae surgery or after having a baby. Common presentations in my clinics would include urinary stress incontinence, incontinence, overactive bladder, women who just perhaps don't feel quite right after having a baby, after having C-sections. We have clients coming through with chronic pelvic pain, so back pain and hand in hand with that pelvic pain, and also some issues including vulvodynia, chronic pain underneath, preventing them from having relationships.
Yep.
And we also get men coming through as well, pre and post surgery, and men with similar types of symptoms, incontinence and pelvic pain.
Yeah. And you mentioned recently about you seeing a lot more younger women coming through. Tell me a little bit about that, because that's really interesting.
Yeah, so I think just, again, because I've always attracted women, I've always attracted pregnant women and postnatal ladies. So lots of my ladies in Liverpool are postnatal. And I sort of recognised within that market that a lot of them are very embarrassed about talking about their problems. So I wanted to reach out to that particular group of women on Instagram mainly. So now we do get younger women coming through with pelvic health conditions that can often be treated, but they're often so embarrassed to talk about it.
Yeah.
I link in a lot of gyms, and the personal trainers know about it and then can recommend them to come to myself. But you don't have to be over 65 to develop pelvic health issues.
Yeah.
In fact, most of our chronic pain population is predominantly within the 30s, 20s, late 20s and 30s.
Yeah.
Our own statistics.
Yeah. And what sort of things do you feel causes that?
I think it's very multifactorial. There's lots of different contributions to why patients present with symptoms. And sometimes, in its most simplistic form, it can be mechanical. So, sometimes women can come through after having a baby and the pelvic floor is weakened and they lose that support system. But with chronic pelvic pain, you get lots of different factors that can contribute to it. including anxiety, a history that builds up over a period of time, again, with very specific factors that can contribute to that. Every patient, and this is, so true, but hands on heart, that walks through the door has a really unique presentation. And it's probably one of the reasons why I'm so passionate about physio and pelvic health still. I'll never really, I don't think anyway, get bored of it. Everyone presents with their own unique presentation. So we can't box it off and say, oh, that's the reason. It does become more complicated when you're dealing with chronic pelvic pain because of all the different factors. And, it's not often physical. It can be, controlled completely. Brain and pain go hand in hand together. So sometimes we come through with physical symptoms, but actually, we don't need to tap into the physical treatment. And
like you say, so much of this is so embarrassing for so many people because it's not talked about, just like sex isn't talked about. Pelvic floors aren't talked about. And, the more I talk about this issue at women's groups and different things, the more people are coming up to me sharing their secrets that they've never told anyone. They've never even been able to come to somebody like yourself, or didn't even know somebody like yourself existed, which is one of the reasons I wanted to have this conversation with you today. So I'd love to sort of start a bit at the beginning in terms of, what is the pelvic floor, and what are its functions, and why does it matter, our pelvic floor health?
Okay, so the pelvic floor is probably one of those, again, muscles, or the area of the body that I'll never tire of. It has so many different functions. It should just be way up there, gold-plated. One of the two of the main functions of the pelvic floor, support and stability, because close attachments to the spine and other soft tissue structures in that area, it acts as a huge support system. So I often refer to it to my patients as the bottom of the box, if you like. And it's very supportive. So it supports our pelvic organs, so bowel, bladder, uterus for women. So with that support mechanism compromised, obviously then we can develop symptoms as a consequence to that. It has a sphincteric function. So with sudden changes to pressure, when we cough and when we sneeze, it needs to react to stop leaking. And just something that you've touched on as well, really, which is within your role, it has a huge sexual function. And I often find that patients often, they just get embarrassed when you talk about that, really, and you ask about sex. But if you're working with the pelvic floor, you have to talk about sex to patients. It has a contributing factor to sexual pleasure, orgasm. If somebody has chronic pelvic pain, obviously they're potentially going to find it difficult to have sexual relationships, penetration. So that's really, really important. And one of the things that's often overlooked is the lymphatic function of the pelvic floor. So in a similar way to, let's try and keep it really simple, with the way our calf muscles work, perhaps, to pump out excess fluid, our pelvic floor does something similar. So again, it sort of sits bottom of your box, and you have your diaphragm pretty much mirror imaging it from the top. And the two of these work together in unison. So again, with the contractions, it helps to pump away and remove any congestion. And often we see the chronic pelvic pain patients who have chronic dysfunction, present with pelvic congestion type of syndromes.
And how would you know that? What symptoms do they have that displays the congestion? Just curious.
Well, sometimes they can present, they can be very swollen down below, so they can literally just very bloated.
Yeah.
Again, you have multifactorial
of course,
feeding into that as well. They can be sort of quite bloated, lots of discomfort down there. So yeah, I think again, it's really difficult to sort of box off, really. But there are, considerations that we would make when examining people to assess, physically what's going on.
Yeah, no, but that's just great to be aware of all these different functions, because it is such an incredible thing, the pelvis and our pelvic floors.
Well, I just think when your patients come into clinic, pelvic floor stops me from weeing when I shouldn't wee. And it goes much deeper than that. When patients present with back pain, often they can have issues with their pelvic floor as well, because they're so closely connected. When patients have issues with their breathing, so chronic respiratory problems, again, that can directly affect the pelvic floor. So it's all in together, and it goes so much further than just having a little bit of stress incontinence because you've got a pelvic floor problem.
Yeah, absolutely. And so what's on, I think these days pelvic floor problems are so common that they've become like, this is the normal. You look at the statistics around things like incontinence and prolapse. It's just so hugely common. But for me, just because it's common doesn't mean it's okay. And so it's like we've come to accept, you look at, even like on the telly, it will be, the jokes about women weeing at a certain age when they laugh, and it's just become acceptable. And so for me, I'm curious for what's the sort of an optimal pelvic floor look like? What's a healthy pelvic floor look like?
Okay, so if we think of it in a sort of real boxed off way, the pelvic floor itself, just looking directly at the pelvic floor, we need a good blood supply.
Yep.
We need a pelvic floor that has a good nerve supply, good strength, endurance, coordination, tone, flexibility. Good pelvic floor needs to be able to contract, but a muscle also needs to be able to relax as well. And there are obviously certain things that can affect that, including age, menopause, trauma, surgery, and most obvious childbirth as well for women. But then if we think a little bit more globally and the whole body, rather than just thinking down below, to have optimal pelvic floor health, we need to consider other factors, including lifestyle factors. So carrying excessive weight, for example, that's going to push down on the pelvic floor and affect our pressure management system. So as much as we know that good functioning pelvic floor needs to have a good blood supply, good nerve supply, tone, coordination, we need to think about all the other factors above and below that as well. Smoking can affect the pelvic floor. It can affect how with the pressure management, it can affect the blood supply to it. The fascial support system is really important. So generally people who exercise have a stronger pelvic floor than those people who don't. So we're not just thinking about the pelvic floor muscles, we're thinking about the quality of the tissue that feed into the pelvic floor. So there are fascial links. Glute max via this fascial system connecting to the pelvic floor. That's really important.
Yeah, so much, isn't there? I mean, we're just touching on it today, but it's just really good to give us a flavour and put it all into context of the rest of the body. And also, I think just to highlight what you said then about sort of tone and suppleness, because I think there's a trend I see with some of my clients about this desire to have a tight vagina. And actually, a tight vagina can often mean a tense vagina. And so I think it's that you want to have that, I sort of describe it like a trampoline. You want to be able to have that bit of bounce, and you don't want it too weak and you don't want it too tight either. So there's that aspect to it as well. So I found from talking to the women, that there's so much information about looking after your pelvic floor, and often I find that people only look at this area when they've got a crisis. So something triggers the need to look after it. But in terms of prevention, we're not very good in this country compared to, say, France, where they have incredible system after childbirth to help people, women rehabilitate. So if someone wants to start to look after their pelvic floor health, where's a good place to start? What's important?
I think I probably just touched on that a little bit really when we were talking about lifestyle factors.
Yep.
You don't all need to go away and literally concentrate solely on Kegels, for example, and pelvic floor exercises. But let's think about those other contributing factors that can influence pelvic health. So nutrition is really important. And when I mention nutrition to my clients, a lot of them think straight away that I'm talking about weight management, but I'm talking about the quality of nutrition as well. So constipation, for example, is one of the major causes of women developing prolapse. So we need to have good nutrition. So we have good gut motility, good gut health. So optimal gut health is really important for optimal pelvic floor health. The two go hand in hand together. Lifestyle factors such as, again, avoiding smoking, the right levels of exercise, stress management as well. The relationship between the diaphragm and the pelvic floor is hugely important. The two relationship, they work well together. So if we're stressed within our lifestyle, what's going to happen to our breathing? And we're going to keep ourselves really tight. It's going to adversely affect that relationship between the diaphragm and the pelvic floor, which can affect our pressure management. And posture as well. And I'm not sort of, years ago when I trained as a physio in like 2001, it wasn't a long time ago now, unfortunately, but we used to talk about things in a very biomechanical way.
Mm-hmm.
You have to stand like this and you can't stand like that, and oh, you're kypholordotic. And sometimes my patients come in and they go, oh, I've been told I'm lordotic. You know, it's
Right.
just irrelevant because there's more than one way to move, there's more than one way to stand. But let's have a little bit of common sense about this as well. Let's think about our pressure management. If you're 3 stone overweight and you're constantly hunched over all day and lifting heavy things, that pressure management isn't optimal for an optimal pelvic floor. So it's just having some common sense factors that, you know, we need to consider. And I think as well, thinking about how we look after ourselves, for women in particular, after having children. So just making sure that we don't go back to doing what we did 6 months before getting pregnant too soon if we're recovering from a C-section or a difficult vaginal delivery. When I see this all the time with my younger girls, they want to get back straight away. They want these washboard flat stomachs. And, you know, we may have survived the trauma of carrying a baby full term and having a challenging vaginal delivery without any symptoms. But if we then go and perform movements and tasks with suboptimal loading strategies, of course that's going to affect what's going on, again, from that pressure management point of view, and affect potentially our pelvic floor. So often we see women present with these symptoms that have built up over years.
Okay.
And women often present to me, so I tend to, within my women's health clinics, get 2 types of clients. I get the younger girls, postnatal or the chronic pelvic pain patients. And then I get the women who are perimenopausal. So typical presentation, late 40s or 51 average age for menopause in this country, just early 50s. And they say, do you know what? I was always feeling a little bit weak down there, but actually all of a sudden, now I just had no control down there whatsoever. So you wonder whether, again, it's how they've been managing their pressure management over a period of time. And you look at things like weight, posture, activity.
Yeah, well, you know, that's how I originally met you, because I came to see you about having a prolapse. And, you know, for me, it's been those lifestyle changes which have been fundamental. So, for example, I'm standing up now at a standing desk because I would just get lazy and hunch over. And how I lift, you know, didn't really understand the relationship between all of that. So there's so much to do that we can look after, but it's not going to affect just our pelvic health. It's going to affect the whole structure of our body, isn't it? There's so much to consider. So,
and the move as well. Sorry, there's just you know, clients often think I have to move like this, and you know, we can't teach our new mums that every time they bend down and pick up their baby on their car seat, they have to bend a certain way, because life doesn't do that. You know, we have to respond to the task ahead of us, in front of us. But actually, we can all improve. Even though there is more than one way to move, most of the time we can all improve the efficiency of how we move, and that's very.
Yeah, no, absolutely. And so I'm curious. So if people have want to, you know, because what I see is that we need to have a baseline of the health of our pelvic floor to be able to do for example, do the right type of Kegels if we were going to exercise our pelvic floor. And for me, it's been so helpful getting that baseline and understanding where my strengths are, where my weaknesses are. So obviously somebody can come and see a pelvic health specialist like yourself to get a tailored program of exercises to help with their pelvic floor, whether it's strengthening, whether it's learning to relax. But if somebody's not able to get access to a pelvic health physio for all sorts of different reasons, might be location and different things, because it's unbelievable how few of you are around given the need for this. Is there a way that women can get to just assess their own pelvic floors and get some sense of how they are down there?
Yeah, I've thought long and hard about this question. Because I'd love there to be, yes, there's this test in place to find out if your pelvic floor is functioning well, and then there's this test in place to, you know, do you see what I mean? It's either A or B. The reality of it is, though, I don't think anything takes place of a thorough assessment with a clinician who's trained in that area. But I think the message to pass on to anyone listening to this is that if you are experiencing any pelvic health symptoms, like incontinence, urgency, where you feel like you literally need to go to the toilet all the time, and perhaps when you need to go to the toilet you can't quite get there in time, bladder irritability, painful sex, these things are not normal. So I think first of all, that's, the first port of call. So when we assess our patients as physiotherapists, sometimes, and I say sometimes, it can actually happen quite a lot, we can do an objective assessment. And the objective assessment, as far as I'm concerned, as a physio, forms just a very tiny part of it. I get most out of my patients within that subjective assessment. So we can assess somebody, and I've done it a few times already this week. It's only Tuesday, isn't it? So literally I assessed a couple of women yesterday, and they were complaining of prolapse symptoms. So we screened them, we used a validated outcome measure, I thoroughly assessed subjectively, asked lots of different questions. But when I came to actually assess them objectively, there's no prolapse there.
Okay.
I could feel. Even got one of them jumping up and down in her leg, one leg. Okay. However, despite the fact that right then at that moment in time, I couldn't feel anything, her symptoms subjectively were telling me that something was going on.
Okay.
So there isn't just one simple test that will say yes or no. Often down to what you're feeling. So if you are having any of those symptoms that we've mentioned already and more, that's not normal. And then it is time to seek professional advice and support. Yes, you're right. Pelvic health physiotherapy. There's not many of us out there. I mean, my personal goal next year, and I'm really just trying to figure out how I can do this actually. But I would like to somehow reach out more to, like myself, the MSK market, and give them the skills to screen people. They are seeing people like this all the time. Statistically, 1 in 3 women over 40 will present with these pelvic health issues. And more so with certain population groups. So actually, the question should be asked. GPs can help and refer on as well. But if you have identified any of those symptoms, obviously we need to try and get professional advice. So it's not always physically what you feel. It's symptoms as well. If we are just keeping it simple and thinking physical, some women come through and ask if it's normal to have a little bit of a bulge there. And women are experiencing prolapse symptoms. They can also feel quite heavy underneath. Sometimes people don't feel heavy, they have the soft tissue protrusion instead. You know what's really interesting, Sarah, I don't want to go off here, sorry, but literally most of the women, and you might be able to identify this in your role, they've never looked at themselves before until they've had a problem. So they don't really know what their normal is.
That's such a good point. I was going to say that because I say to women, look, if you didn't look at your face in the mirror for 10, 20 years and then you had a look, you would get a shock. And so it's like, just look every now and then to, like you say, connect to what your normal is, because we do change. Our vulvas and our vaginas do change for all sorts of different reasons. And also, just to keep so many women I've worked with not even touch themselves down there for all sorts of different reasons. And so actually just by connecting there and feeling, how does it feel? Actually, it does feel a bit looser, or I do feel some tension there. Then it can help you to exactly what you say, get to know what your normal is. And actually, it does, if you can connect over a period of time, actually, and when I listen, I actually do feel there's some tension there, and maybe I do need to get this checked out, or I do feel something shifted, but I don't know what. So, for me, when I had my prolapse, coming to see somebody like yourself was just worth its weight in gold, because when these things happen, as you know, they can build up slowly over time, or like mine happened very, very quickly. And so I just went into panic and terror over my sense of my organs starting to fall out, and seeing somebody like yourself, don't look on the internet at that stage, go and see someone like yourself, because the messages are so negative.
The internet can be a really scary place. And I think that's the point I'm trying to get across. I think as much as it'd be great to self-diagnose, I would not be myself the best person to clinically assess any symptoms I had in my body, because it's just, you need somebody else to look for you who's trained. Pelvic health, like any type of presentation in physio, whether it's back pain or neck pain, so unique to that individual, and there's so many different factors that contribute to it. Sometimes you can read up on the internet and actually you can self-diagnose a problem that might seem quite straightforward, but as much as it would be unusual, it could actually be a bit more serious than that. And as a health professional, we're trained to be able to screen, identify red flags, look for things that shouldn't be there. It doesn't happen very often, but there have been cases within my career since I qualified where I have picked up things and I've sent on. And then also on the other hand, you could read something and, like you say, completely catastrophize it. Oh my gosh, my organs are falling out, literally. And it's like, actually you're okay. No
absolutely. Absolutely. And I think that's another important point as well, because I think if you're wanting to do some exercise to look after your pelvic floor, going to see somebody like yourself can be really important to get a baseline, because if you're already got a lot of tension there, if you choose to do something like Kegels, then you can make it worse if you do the wrong type of Kegels. So I'd love to just hear from you a little bit about, what is an optimal Kegel? And we've got the two types of Kegels, the sort of normal Kegel and the reverse Kegel. So I'd love you to just talk a little bit about that, because I think, again, there can be so much information.
Yeah, so just to sort of mention as well, actually, a lot of my patients come into me and they say, so what's the difference between a Kegel and a pelvic floor exercise? Now, as a clinician, I've never really sort of called them Kegels myself, but they are these pelvic floor exercises. So just to clarify that really for any patients listening. And then the reverse Kegel, for me as a clinician, is, well, the Kegel and a reverse Kegel, for me, it's the ability to be able to contract, to be the Kegel, the pelvic floor, and then to relax, to let go. There is some evidence out there to suggest that for women, the most efficient way to achieve the pelvic floor contraction is a little bit different than how we'd cue it in for a male pelvic floor. For the female pelvic floor, we want to be able to get a back to front contraction. So anus to pubic bone.
Yep.
I got a bit carried away there, not my computer. Anus to pubic bone. So we want, when we palpate this as physiotherapists, we want a symmetrical contraction. Sometimes we feel that one side of the pelvic floor might lift more than the other. And it's actually the lift that we want, rather than downwards displacement. Like up to 50% of people, in fact, it's more in my clinical practice of the population that we're working with, but apparently up to 50% in some of the studies that I've looked at, people do not know how to do a pelvic floor contraction. And a lot of people will do what we call a Valsalva technique or maneuver, so they'll push down instead.
That's what I was doing.
Yeah, and a lot of people are, so they end up pushing down, which almost creates this pressure. And actually, anything doesn't help what we're trying to do. So you have a prolapse there. We don't want to push down. We want to lift. We want to get this back to front activation, symmetrical from side to side. And we should be able to hold it. And the pelvic floor has two different types of muscle fibers, type 1s, type 2s. So type 1s are your slow twitch ones that literally have to work all the time, really, from a postural point of view. Remember that pelvic floor is the bottom of your box. It has quite a lot to support. And then we have your type 2 muscle fibers, and they're the ones that react quite fast when you cough, sneeze, the fast muscle fibers. 70% of your pelvic floor is type 1. So we should be able to demonstrate that we can hold pelvic floor. And if you were to plot it on a graph, ideally, we should be able to lift and then hold and then relax. But we should also be able to coordinate the pelvic floor well. We should be able to switch on and off. We should be able to go right back down to where we started from. And we should be able to go up and down again. So remember, for the female pelvic floor cue, we have that back to front. And the male pelvic floor cue tends to be straight up. So testicles to spectacles, nuts. They might not work for everyone. You've got to be quite careful who you use your cues with. Imagine for the male pelvic floor, they're walking into a cold ocean, for example, unclothed. We have women who have obstetric anal sphincter injuries, and again, you might want to sort of bias a little bit more of that sort of anal and sphincter involvement. So again, we sort of go back to front, but we can tend to focus on winking the back passage to get that sort of anal wink and to hopefully involve a little bit more of that sphincter.
Fabulous. So the one I like is that the idea of like a zip, so it comes from the back to the front. So there's lots of different ways, isn't it? But just to be aware of that. So thank you for sharing that. That's wonderful.
And then we've obviously sort of spoken about the activation of the pelvic floor for the Kegel, as you described. The reverse Kegel, as much as we need to be able to contract muscle, we also need to be able to let go. Now, for some people, they don't need any cueing with that. And, you know, we don't want to over-cue as well. So something that I found as a Pilates teacher over the years, we can over-cue. You know,
what do you mean when you say cue?
Cueing, so giving an instruction.
Okay.
So, exhale, switch off. Sometimes we can give too much input to confuse us, because, you know, breathing is normal. Breathing just happens anyway. Do we really need to focus on the breath when the patient's doing it anyway? or do we make it bespoke for that person struggling and they need to focus breathing in the right place rather than their shoulders, for example? We might need to do that. But I think we are guilty as physiotherapists of overdoing, so we don't always need to do that. So for some people, when we feel their pelvic floor, and when we look at it perhaps on biofeedback or even with the real-time ultrasound, they just relax naturally. So that's fine. For some people, they contract and then they just sort of hang around there and then they don't really let go.
Okay.
And that doesn't mean that they're strong. It just means that perhaps they haven't got that coordination or the cognitive awareness. They might have a dysfunction there. Just because the muscle is overactive, it doesn't mean it's strong. It'd be a little bit like having your biceps sort of held on a permanent state of tension all the time. And that can be connected to pain. So there are a certain group of patients that we might have to get them to connect into that relaxation a little bit more. And one of the nicest ways to do that is to get them to connect into their diaphragm. So again, that pelvic diaphragmatic relationship. As we inhale, the pelvic floor should descend with the diaphragm. And as we exhale, move and lift up. And that's one of the first lines of treatment that I use to be able to get them to connect with the relaxation. For other women, we encourage opening of the pelvis, stretching of the muscles that feed in to the pelvic floor, adductors, glutes, just letting go, learning to let go. I did a lovely workshop actually in Belfast, and I'm doing one with APPI. I'm doing 3 more up and down the country this year about pelvic floor activation and the function of the pelvic floor. And again, as physios and Pilates teachers, they're so obsessed with switching on, but letting go is probably more important in my world at the moment. I see more people with overactive pelvic floors than I do with pelvic floors that just can't work at all. So it's often a letting go that's the issue.
Yeah, no, I think it's really important to raise awareness around that as well, that is a possibility. And I see that a lot in my practice with women who are stressed out and over just, so busy and that tension that's created in the pelvic floor for all sorts of different reasons. So wonderful. Well, thank you so much. It's been really fascinating getting insights into your practice. And hopefully for women listening, all genders listening, that, if you've got any symptoms and issues that you feel more motivated or encouraged to come forward to somebody like Sarah to get your symptoms checked out. But also if you haven't got any symptoms and you're just curious and you want to check how your pelvic floor is, or you want to look at how you can maintain your pelvic floor health optimally, I really recommend going to see somebody like Sarah. So Sarah, tell me where people can find you.
So my clinics are in North and South Liverpool. We have a clinic in Mossley Hill and we have a clinic in Crosby. And we've just launched our new Pelvic Power service in Mossley Hill, which is just adding on a different dimension to our pelvic health services. But we see all types of pelvic health presentations. And we often do pelvic health screening assessments as well. So women who, particularly postnatal, who would just like a check after having a baby. Men, before going for any type of surgery, I'm thinking of the more common one that we see. So surgery, prostate surgery is a cancer. Just MOTs beforehand. And screening them afterwards. So we have a team of practitioners who are trained to deliver pelvic health services.
Fantastic. And what's your website?
So it's the physiotherapycentre.com.
The physiotherapycentre.com. Wonderful. Well, thank you so much for listening. And if you would like to, I'd love to hear how you find this. Please put any questions in the comment box below and I'll keep an eye on the questions. And if you've got any questions for Sarah, I'm sure I can forward those on as well and we can take a look at them. And also just to do a little promo for my 4-week course, V-Life, which is coming up on June the 11th. V stands for vulva and vagina. And it's a 4-week course to explore all things around our vulva vagina, everything from our pleasure to pelvic health, to our relationship, our connection, our knowledge, our anatomy. It's the full thing. So I'll put a link to the course below. And if you've got any questions about that, do let me know as well. Thank you for listening. And thank you so much for joining us, Sarah.
Thank you.